You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello and welcome to Streetside, the official podcast of the Street Medicine Institute Student Coalition. I'm your guest host, Michael Brennan, and today I am very fortunate to have with me Dr. Patrick Perri, who is a member of the board of directors of the Street Medicine Institute and also the medical director and co-founder of the Center for Inclusion Health through the Allegheny Health Network in Pittsburgh, Pennsylvania. Dr. Perri, thank you for coming, and we're so honored to have you as a guest on the program and look forward to talking with you. Would you take a moment and just introduce yourself a little further?
Sure. First off, thanks, Michael, so much for inviting me for this opportunity. Really appreciate that. But my name is Pat Perri, and I'm a street medicine doc at heart. That's the thing that has kind of grounded my career and focused my career. I've been excited sort of from the beginning of my medical education about the idea of street medicine. And through my work, both as a student, then as a resident, as a young faculty member, in street medicine, I started to see some of the larger themes beginning to emerge around what it was that we were learning from our friends on the street that taught us about the weaknesses in our health system, in our medical education paths, and in some of the upstream policies that were contributing to people remaining in a state of suffering and homelessness and despair, cut off from society. My path is one that is somewhat traditional. I was heavily influenced as a student by some of the leaders in street medicine, like Dr. Jim Withers and Dr. Jim O'Connell. I had the great opportunity at the University of Pittsburgh to volunteer with Dr. Withers' organization, Operation Safety Net, to be a regular member of their outreach team and log a ton of time on the streets, which solidified my kind of passion for a career in street medicine. And I said to Jim at the time, what do I do next? Where do I go to sort of pursue this path? And he said to me, very wisely, you need to go to Boston now. And in Boston, the Boston Healthcare for the Homeless program, which has been shepherded by Jim O'Connell and really rooted in street medicine work, although a huge sort of networked umbrella of homeless healthcare around it. I was able to do my residency in Boston at Mass General Hospital. That gave me an opportunity to not only get great clinical training, but continue to work with BHCHP. And after graduating residency, lucky enough to be hired by BHCHP as a member of their street team, where I worked for 10 years or so, and eventually moved back to Pittsburgh to create, which is my home, and able to create some innovative programming in Pittsburgh that's been kind of the highlight of putting down roots and investing in something that was much bigger than just my clinical practice.
Tell me more about that. The Center for Inclusion Health. I love the title of that, and I think our listeners will wonder, what's the genesis of that, and what is the vision for a Center for Inclusion Health? Unpack that for us a little bit.
It's a great question. Get this question a lot, especially in the U.S., where folks haven't heard that term. It's not that inclusion health, the concept is so much different than other concepts that they're familiar with, like health equity or care to underserved populations. But we chose that term very intentionally. This concept has been alive in the UK for a good 15 to 20 years. And in the UK, they sought that term to describe a group of people that they were seeing who were profoundly socially excluded. It turned out those groups of people were also quite politically noisy. So there was significant pressure to sort of have a set of interventions that would address some of the problems that were being seen with folks experiencing gravely disparate health outcomes and poor health access. So that term inclusion health became a convenient way to gather under one umbrella this idea about looking for populations that suffered from multiple deprivation or multiple exclusion and were at an extreme end of the social gradient in health. Sir Michael Marmot, who's an epidemiologist in the UK, described this very well, the underpinnings of the social determinants of health and movement, and some of the sort of newer evidence that was gathered through this transatlantic partnership and was invited by a prominent medical journal, The Lancet, that we put together an understanding about what mortality looked like for folks who are at the far end of this exclusion spectrum. And that included a bunch of groups: people experiencing homelessness, people who were incarcerated, people who injected drugs, and people who were engaged in commercial sex work, even traveler populations. And that research demonstrated that the standardized mortality rates for that group of people in a variety of high-income countries was more than tenfold relative to other populations who were not nearly as socially excluded. And so that underpinned the work and created a movement, the inclusion health movement. By definition, it is a research, policy, and service agenda that aims to both prevent and redress the health harms of extreme inequity. It is a justice-focused movement, and it is a sort of universal principle that can be applied locally to a particular community's or population's struggle.
So it's a model for the nation, the world, maybe. I'm curious how it operationalizes in your world. You are the founder and director of the Center for Inclusion Health. Tell us more about that. More details. How many providers? Who are your patients? What are you actually doing day in and day out?
Sure. So in Pittsburgh, in creating the Center for Inclusion Health, we were really hoping to respond to a number of groups of people in our community that were profoundly excluded, marked by either lack of access to adequate care or very disparate health outcomes. And when we think about exclusion, the tendency is to frame that as people who are unable to access health care. We're lucky enough in Pennsylvania as a Medicaid expansion state where many people who live in poverty have access to Medicaid. That doesn't mean that they have access to adequate health care. And so when we look at some of those populations who are effectively shut out, not because they don't have health insurance, but because they can't get the kind of care that they need in the right places at the right time with the right amount of cultural humility. And so one of the things that we said is, all right, let's try to identify some of those populations in our community. One of them were people who are experiencing unsheltered homelessness, also known as rough sleepers. We are at the epicenter of the opioid crisis, so focusing a lot on people who inject drugs, particularly opioids. Also, folks who experience gender dysphoria, transgender populations, people living with HIV, immigrants and refugees, victims of intimate partner violence, people who have recently been incarcerated. These are all populations that the Center for Inclusion Health has really created programming around. To do that, we made a very practical decision to locate ourselves within a health system, within Allegheny Health Network, and we created that as a division within the Department of Medicine. So we have equal academic and administrative standing as the Division of Cardiology or Endocrinology. That enables us in a very justice-focused way to not only include the populations we are working with as part and parcel to patient care delivered by the health system, but it gives us a unique opportunity to work from inside of the health system to effectively communicate the needs of the folks that we are hearing, to advocate for them, to achieve some of the upstream policy changes that will help to prevent them from remaining excluded and to prevent the health system from participating in creating more excluded people.
Tell me more about that. We as clinicians provide care to individuals. When you talk about advocacy and changing the upstream forces that are forcing people into being unhoused, rough sleepers, how do you all do that? What's your advocacy wing?
One of the biggest things that we pay attention to is this idea that the best instructors of system change are people who have been excluded or failed by those systems. And so in our street medicine work, we are continually listening and learning from our brothers and sisters on the street. One of the ways that that's been framed is to think about a problem like excessive mortality among people who sleep rough as not only a social failure, but a healthcare failure. And those folks can be very effective stress tests for health systems. When we see someone discharged from the inpatient environment to an unsafe setting that sets them up for worsening of their health, recurrence of problems, readmission to the hospital, or when we see constructs where people only feel like they can access care in the emergency department, and their needs are not necessarily ones that are well served by emergency departments, we find that systems level work is what can help us to better meet their needs in ways that not only benefit that population, improve their morbidity, their mortality, their quality of life, but also help the health system to function more effectively, more efficiently, and better meet their mission.
Fantastic. Well said. And curious question: do you offer medical respite? Is that part of your care?
Yeah. So the Center for Inclusion Health started the first medical respite program in Pittsburgh. We did that on an operational model that was really focused on people who inject drugs and were admitted to the hospital with deep tissue infections, osteomyelitis, endocarditis, things that would require long-term IV antibiotics. In Pennsylvania, skilled nursing facilities are very reluctant to receive these folks on discharge to complete care because of perceived liability. And they don't do well remaining in hospitals for the completion of the course of treatment. That environment tends to be quite claustrophobic. Sometimes the care delivered can be, if not unfriendly, downright antagonistic. And so we created medical respite on this model that by discharging those folks from the inpatient setting to a setting that was safe, where they could continue their recuperation, receive ongoing treatment in the form of IV antibiotics in a way that was much more comfortable and where patients had autonomy, but in a harm reduction focused setting, which meant that if folks chose to continue their use of substances, that was okay, as long as they were engaged in completion of their treatment. And so we created medical respite on that model as a cost avoidance opportunity for the hospital.
Which made it more palatable for all involved, right?
For sure.
Yeah.
The surprising outcome of that was not only there was significant cost avoided by moving folks into that lower cost setting, but the thing that really surprised us is that their completion of treatment was better than the intention to treat of remaining in the hospital.
That's profound. Which leads me to a question about your research. Do you have numbers to show that the overall community health has improved because of your existence?
That's a great question. And I can tell you that around certain populations, we are able to demonstrate significant differences in the way that they utilize acute care resources or their access to care, one of the most kind of fulfilling parts of our work has been working with people who have opioid use disorder on the streets and engaging those folks, creating programming for them that met those needs in ways that they were comfortable with. To walk into a clinic for folks who have been so marginalized, had developed significant mistrust of healthcare systems because of the stigma that is associated with their use, is very difficult. And so we also know at the same time that medication for opioid use disorder in the form of buprenorphine can be highly effective in that group. And so the question was, how would we bring those two things together? And the street medicine model was part of the answer to that. By going to the streets, developing relationships with people, rebuilding trust, we were able to introduce, when people are ready, able, or willing, the idea of buprenorphine treatment for them, can initiate in the street setting, and then walk back in to the clinic setting with them. Same providers in both places, which is a key part of the street medicine model. So there's very minimal trust grafting, and our ability to engage that population out on the street and then retain in a clinical setting where we had more supports, peer recovery specialists, and primary care access really made a big difference.
I love that continuity. That can make such a difference. And you hear in kind of high-end medicine, concierge medical care. And I've often thought that street medicine is its own concierge medical care. Would you agree with that statement?
Yeah, that's a really interesting way to put that. I think that people on the street deserve really good care, and sometimes I think they deserve better care. And the reason why I say that is that, according to this, back to Sir Michael Marmot, according to this law of proportionate universalism, which says, look, everybody has the same needs. They just vary in intensity or variety depending on what part of the population you look at. So folks get the same intervention, but at differing concentration, differing intensity. And I think it's fair to say that folks who live on the street are living in a state of inequity. And so their relative need is higher. The needs might be the same, but the intensity with which it should be delivered, not only be uniquely delivered, but at a higher intensity to create equity makes sense. So my way of framing that is that they don't just deserve care, they deserve great care.
And it sounds like you're providing that.
We try.
Yeah, well, good for you. How about the training of medical students and residents? Is that part of what you do?
It is. We are very, very grateful to have medical learners be part of that experience. At Allegheny Health Network, we have an internal medicine residency training program, and we work closely with them. In fact, inside that program, we've created an inclusion health track, which allows 3 to 5 residents per year to participate in a way that is longitudinal across their training and gives them deep exposure and mentorship around the skills that they will need to be effective inclusion health practitioners. That includes advocacy, that includes interpersonal communication, that includes exposure to excluded populations, and the kind of systems level work that it requires to work upstream of those problems.
I'd like to get down to the patient level for a moment, and I don't want to put you on the spot, but there are narratives out there of our patients on the street, and I'm wondering if you would tell us of a patient that was a particular success in your many years of doing this. Does someone immediately pop to mind?
They do. I can think of a person, and I want to reframe the idea of success.
Right.
I think the stories that we often hear in mainstream media about what success looks like are wonderful outcomes. In the world of street medicine, though, we learn very carefully to set our bar for success at the same place that our patients set the bar for success. So we follow their lead, we work from their agenda, we let them set the pace and the context for the way that we help. And one of those stories comes from my time in Boston, where we visited as part of our street team, got to know a gentleman who slept outside one of the major train stations. And our interactions with him were very brief, but we always made sure at the end of every visit to say, could we come chat with you again? Never did we deliver anything that looked like medical care. At most, it was a sort of icebreaker or peace offering of a cup of coffee or maybe a sandwich, some clean socks. And this went on every week for about 2 years. And then finally, one time in year 3, it was particularly cold outside. It had rained the night before. Although this gentleman didn't say much, he was able to communicate that he was really feeling cold and he was having a hard time getting around because his feet hurt. And we just sat silently and let that hold space. And finally, he looked up, and he rarely made eye contact, but he looked up and he said, "Will you look at my feet?" That's a success story. That was a development of a relationship that took 2 years in the making, and it never would have happened. He wasn't going to seek care on his own. It never would have happened if there weren't consistency, if there weren't gentleness, if there weren't curiosity and trying to understand the reality of his situation, that we got to look at his feet and do some foot care and then build from there to engage him in more regular contact, eventually in something that looked like comprehensive primary care, and built to other changes in his life. So that's a street medicine success story, is, will you look at my feet? Beautiful.
Beautiful. Love that. I'd like to ask then at a more personal level, as Pat, doing this work for decades, what brings you the most joy, the most fulfillment, pleasure from this work?
I'm a lover of stories. I really enjoy seeing the arc of people's lives and being invited into that, to be a participant or a witness in their narrative arc. I feel like a hunter-gatherer of stories, as Jim Withers once said. That for me is the romantic part of this. And it is a remarkable sort of joy and privilege as a physician, as a healthcare professional, to have someone invite you to that space. It is sacred, and can be found anywhere, but we find it in high concentration in street medicine. That's a place where the fundamental moral core of what it is to be a healer is the most evidence. It's stripped of the bells and whistles and protections and false armor of the hospital or the clinic, and it requires a person to be real, to be human, to be vulnerable, and for there to be an opportunity for bidirectional healing. That's the best stuff. That's where the joy is.
It's therapeutic, is it not, to do this work? And I feel like it is we're all wounded healers, and we are healed through this process by the people we think we come to serve, who end up serving us. And I just love that bidirectionalness to the work. Mm-hmm. So well said. We're going to ask just 2 more questions. I'm going to ask you if you could tell our listenership one thing that you could suggest that they could be or do to make the world a better place.
One of the things that I often encourage my learners to do is to don't just do something, stand there. And what I mean by that is to take it in, to appreciate the context of someone's life, to think about their circumstances, to be curious about their story, and to listen and to observe. When we do that, it's so much easier to understand what's really ailing people. What about our systems have, failed them or benefited them? And it's much easier to respond as a human being and not a preconceived construct of my role. And so that, I think, brings a lot of gratitude and fulfillment to the people that we serve, because they feel like I've been seen, I've been heard, this person gets where I'm coming from. And it's not always about fixing it, but simply having some solidarity around that. And so I think that this is the way that we come to and embrace solidarity, and that we connect as human beings by first being curious and appreciating the context of a person's illness, of a person's well-being. That's what matters.
It's sounding like some curiosity is in there, and some mindfulness, just a presence of being with someone, and in their suffering, maybe just being with them in that suffering.
Yeah, it's
empathy and compassion and caring and all those beautiful things.
It's one of the best gifts that we get, and that we give, is that opportunity to hold space with people.
Yeah, thank you. Last question then. Our listeners would like to learn more about your work and support you. What would you recommend that they do?
I'll tell you, the street medicine movement really is sort of shepherded by the Street Medicine Institute. This is an organization that helps to train and increase capacity for people to deliver healthcare in their communities to people who are experiencing unsheltered homelessness. Street Medicine Institute is not only a great resource, but very important for ensuring that we have a chance at equity and inclusion for our brothers and sisters who are sleeping on the street throughout the world. So I would encourage folks to visit streetmedicine.org. If they want to support the work, there's an opportunity to do that there.
I was struck. I'm just going to close with this and let you respond to it. But I was struck. There's a photo. We're at the International Street Medicine Symposium in Kansas City. And in the brochure, there's a picture of the first Street Medicine Symposium in 2005 with about 40 to 50 people in it. And I think today there are 500 people. What does that speak to you?
It says a lot of things, I think. It tells us that, number one, we're so glad that this many people have become interested in that work, that there's opportunity for them to do that work, that there are better lighted paths than there ever have been to engage in that work. And it's also tragic that this many people are here, that we are bringing folks of great talent and great compassion and great social concern to address a problem that shouldn't exist, that we are a workaround, that we are trying desperately to teach back to mainstream systems, whether healthcare or social systems that haven't worked out well for folks. That we're here and that this group is so large continues to be a tragedy.
Thank you for that. Thank you. And Pat, thank you for taking the time for this interview. We really appreciate your time, your commitment, your work, and your wisdom in providing this care to our unhoused, unsheltered brothers and sisters. So thank you for being a guest on Streetside.
My pleasure, Michael.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice and instead see your own provider for medical care.